Hello, I'm Robert McMullen. I'm a psychiatrist. I went to undergraduate at Washington and Lee. I did medical school at Georgetown, which I might add is a great place. And I did my residency at Columbia, another great place. Excuse us for the noise outside. We've got some construction going on out there. I've been doing medication, psychopharmacology, for over 30 years. And also in about 2010, I added TMS, transcranial magnetic stimulation, which are these giant magnets that you put over the brain and either stimulate or inhibit certain areas. And then there's one machine we have that's a helmet, BrainCare, that the magnetic field goes in a lot deeper. But what I want to talk about is elderly depression and treating it. It's very frequent that people with depression when they're elderly have had chronic depression all their life, and they may still be on medication that was working before, and maybe some alterations have to be made. It has to be kept in mind that whatever they're taking, they are probably metabolizing it much more slowly, and so they should be on a lower dose. One lady I have that's in a residence right now, and I've been treating her some 30 years, and now she's in her 80s. And recently she had a medical problem and was hospitalized for a while. And they took her off for sertraline. And I believe she'd always been on 100, maybe 150. But she's weaker and older now and had been off of it some time and was really severely depressed. She was severely depressed. And in the past, she would have a tendency to pretty severe depression, but she was on this medicine for 30 years, so she was fine. And I went much more slowly. I did 25 milligrams, I think, for a week or two, and then I went to 50, and then I didn't want to go higher. And she was, slightly desperate, because she was in real pain. But I said, let's wait. It's going to work. We'll just wait. And then after 3 or 4 weeks, she suddenly got better. She came all the way up to normal, and she feels fine. So sometimes you should just use a low dose and wait. And as you go up, just be careful. If you over-sedate them, then they may trip more easily when they go to the bathroom in the evening because of the sedation, maybe because of a little low blood pressure. It's not so bad if you fall down, as long as you don't break a hip, or as long as your head doesn't hit a hard piece of wood, but you can't count on that. Now, that's one of the major things to remember with the elderly. And you should also, of course, do a lot of lab tests because their thyroid could be off, and this is very important. The TSH, the thyroid stimulating hormone. We've always considered that if the TSH gets up around 4 or 5 or higher, that they're low in thyroid. Because if your thyroid goes low, then your brain puts out more thyroid stimulating hormone to come down here and stimulate the thyroid to make the right amount. And this is always in balance all our lives. But if the thyroid is not responding well enough, then the TSH will go higher to try harder to push it out. Well, one thing that it seems like the neurologists and internists don't all know right now is that the upper limit of TSH shouldn't be 4 or 5, it should be 2.5. And the American Thyroid Society says this, and also the research in psychiatry shows that the biggest predictor of people not coming out of depression is having a TSH below 2.5. So I would really question the doctors about this, because most of them are not going to know this. And it's a little better if you give people cytomel hormone, which is the T3 hormone, rather than the T4 hormone, which is called Synthroid. But in elderly people, you have to go very slowly. You can't give them 25 micrograms like younger people. You have to give them 5 micrograms, or half of 5, and just go up very slowly so they're not overly stimulated or you don't cause their heart to race. One thing that frequently happens with depression in the elderly is it's not diagnosed. And two main places it's not diagnosed is in cancer and when a spouse dies. So when someone has cancer and they have all the symptoms of depression, their sleep is off, their appetite is off, they can't enjoy anything, they're very negative and pessimistic. Everyone says, well, of course they're depressed, they have cancer. But 50% of people with cancer have a real depression. Now, maybe secondary to the cancer or laying in bed all day or something like that. But if you treat them, they feel better. They begin feeling better. They begin to enjoy seeing relatives more. They can plan on enjoying the rest of their life, even if the rest of their life may not be as long. But it gets better. Now, another place it happens is when a spouse dies. Then the internist and the friends and everybody says, well, of course he's depressed. He was very happily married for 30 years and they were very close to each other, so of course he's in a depression. But at the wake, he can't joke with people and talk about old times. But especially in the next few weeks, he still can't joke and talk with anybody about anything. His sleep is off. He's not happy about anything. He's not enjoying anything. He's perhaps losing weight or gaining weight. He's very pessimistic. His self-esteem may go down, even though there's nothing he's done that make his self-esteem lower than it was 5 years ago. And friends begin to call him up to go fishing, or they call him up like they always did to go fishing, and he turns them down, and gradually his friends don't see him. He takes early retirement soon after her death, and after a year and a half, this man is totally isolated and has nothing in his life. His friends are gone, the job he always liked is gone, and if he hadn't been depressed, he wouldn't have left the job. So it's really important to follow people like this and have them treated soon. And this is a real depression. Not until a few years ago, I think, we used to call it a grief reaction. But with a lot of research in psychiatry, they have finally decided that it's a regular depression. It's no different than any other depression. The symptoms aren't any different, and the treatment isn't any different, and the reaction is the same as if some other really bad event happened in your life. Now, there's different things that happen during grief, like people will get flashbacks to their spouse, and a lot of things will remind them of them, and they may literally talk to, people don't know this, but a lot of people talk to their spouse all the time, or go to the graveyard and talk to them, which is really, a good thing. It's a helpful thing. They're just a little embarrassed to tell us much about it. And those people should be treated. And the treatment is really the same as with younger people, just more slowly, with the doses and a little more carefully. And you may even more likely have to use an augmentation strategy rather than go real high with one medicine, keep it lower and add in another type. So you have more than one thing. Just same as we treat blood pressure.
What about TMS? It's good for elderly people?
Oh, I keep forgetting about TMS. Transcranial magnetic stimulation. I've got 4 machines for this, 2 in Mount Kisco, 2 here. And they're 2 completely different machines. One's a BrainCare helmet that goes much deeper, and another is a MagPro from MagVenture, which is the same that they use in research at Harvard and in Toronto and so on. These are actually a very good thing with elderly people because they don't give much side effects. And in fact, practically none. And we've had really great responses from elderly patients. And if they have never had much depression before, it makes it even easier, I think, to get a response. Now, there's some things in the literature saying that they don't respond as well because the brain is shrunk a little, so the brain is a little farther from the skull than in younger people, or when they were younger. So if the magnetic field only goes in 2 or 3 centimeters, maybe it's only going to go into 1 centimeter in somebody older. And this is more true of the MagPro machine, which has something that's called a butterfly coil, 2 coils of copper where you run the electricity through. And one way of getting around that is to do more of a treatment on the right side that's inhibitory. Because an inhibitory treatment is 1 pulse per second. And even if you go up to a rather high dose, you're not at much risk of causing a seizure or anything like that. With an excitatory treatment, you don't want to go to real high doses because you could induce a seizure. But you can go to a higher dose with someone elderly, and then it's going to reach deeper and hit the area you want. And there's also a couple of other places you can treat, like the dorsal medial, prefrontal cortex is down the middle. And then with the BrainCare machine, since it goes 6 or 7 centimeters in, then that distance between the brain and the skull doesn't make any significant difference. And as with anyone that has a depression and is getting TMS treatment, some of them may just need more treatments. You may just have to do a lot more treatments or vary the treatment. You try different parameters, switch machines, switch places where you treat. There's different things you can try. It's also very affordable now if you're on Medicare. For at least the first 30 or 36 treatments, the Medicare pays almost entirely for it. Thank you. This is Robert McMullen. I just talked about some important things with elderly depression.
Thank you very much, Dr.